Hi, this is a video about tiotropium. What is tiotropium and its use in treatment? Tiotropium is mainly indicated for the maintenance and treatment of chronic obstructive pulmonary disease or COPD and severe asthma. It can be used as an inhalation of powder or aerosols. COPD occurs when the lung and the airways become damaged and inflamed. It is usually associated with long-term exposure to harmful substances such as cigarette smoke. COPD occurs as a result of harmful chemicals in smoke, damaging the lining of the lungs and airways. Around 1 in 100 people have the genetic tendency to develop COPD called alpha-1 antitrypsin deficiency. This is a protein that protects your lungs from protease, and without it, the lungs are more vulnerable to damage. People who have an alpha-1 antitrypsin deficiency usually develop COPD at a younger age, often under 35, particularly if they smoke. COPD is an umbrella term used to describe progressive lung diseases such as emphysema, chronic bronchitis, and refractory or non-reversible asthma. This disease is characterized by increasing breathlessness. In emphysema, the alveoli become stretched out, making the lungs get bigger. This makes it harder to move air in and out. As a result, old air gets trapped inside the alveoli, meaning there is little or no room for new air to go in. Chronic bronchitis is an inflammation of the bronchial airways inside your lungs. Cilia lines the airways and keeps them clean by sweeping mucus up. However, when cilia are damaged, these cannot be achieved. Therefore, it becomes harder for you to cough up mucus, making the airways swollen and blocked. In an asthma attack, the bronchial airways tighten and swell. This is normally reversed with the use of medications. However, in refractory asthma, the bronchioles do not respond to these medications. COPD can be treated with beta-2 agonist inhalers such as salbutamol, which binds to beta-2 receptors on smooth muscles, or it can be treated with antimuscarinic inhalers such as tiotropium, which binds to muscarinic receptors in the bronchioles. What is the classification of tiotropium and its mechanism of action? Tiotropium is classified as a muscarinic antagonist, which binds to muscarinic receptors. So what are they? Muscarinic receptors are part of the G protein family. They are composed of 7 transmembrane segments where the third cytoplasmic loop is coupled to a G protein. There are 5 subtypes of muscarinic receptors, which are M1, M2, M3, M4, and M5. The activation of these subtypes result in different protoreceptor signals. Therefore, the selectivity to each receptor is a crucial factor when developing drugs for specific target organs. Acetylcholine binds to M3 receptors in the lungs to constrict bronchioles and increase mucus production. This occurs to prevent particles and dust entering the lungs. This process is active in COPD. Tiotropium competitively and reversibly binds to M3 muscarinic receptors in the bronchial smooth muscles, resulting in bronchial smooth muscle relaxation and reduced mucus secretion.
How was tiotropium discovered? Smoking the dried plant known as belladonna is a remedy for asthma known since the Middle Ages. Fun fact, belladonna means beautiful lady in Italian. This is because the extracts of belladonna dilate the pupils, leading to its cosmetic use in rendering women more attractive. The anticholinergic action of belladonna from dried plant smoking was caused by the presence of alkaloids of the atropine. Atropine occurs as a secondary metabolite in the root of the belladonna plant. Atropine is an ester of tropine with hydroxymethylphenol acetic acid. Pure atropine was isolated in 1831 and is still in use as a drug today. It is non-selective for the subtypes of muscarinic receptors. Atropine has a half-life of 2 hours. The effect of the drug declines after this. Unfortunately, atropine easily penetrates the blood-brain barrier, which generates multiple side effects that include dry mouth, enlarged pupils, blurred vision, red or dry skin, fever, and a fast heartbeat. The chemical modification of atropine yielded ipratropium. Ipratropium bromide is an N-isopropyl analogue of atropine, a synthetic quaternary ammonium compound made by adding an isopropyl alkyl group to the tertiary nitrogen in atropine. Ipratropium seems to be highly selective for M3 and is employed in metered-dose aerosols for the treatment of COPD. Tiotropium bromide has been used as a bronchodilator therapy for COPD for many years. but its short half-life means that it typically needs to be administered 4 times per day, which can cause problem with drug adherence. The clinical need for anticholinergic agents with a longer duration of action was a key factor in driving the development of tiotropium. Tiotropium has roughly a 10-fold greater affinity for muscarinic receptors, which means it's more likely to bind than ipratropium. It also dissociates 100-fold more slowly from the M3 muscarinic receptors, which means it stays bound for much longer and results in once-a-day administration.
What is the structure of tiotropium? Tiotropium has a molecular weight of 392.508 grams per mole. It has 1 hydrogen bond donor and 6 hydrogen bond acceptors. The structure of tiotropium is as so: an epoxide on the amino ring, 2 thiophene rings, 2 methyl groups of nitrogen, a non-chiral quaternary ammonium, a tertiary alcohol, and an ester. The importance of these functional groups will be discussed later in the video.
How is tiotropium synthesized? Firstly, oxalic acid dimethyl ester reacts with 2 lots of thiophene magnesium bromide. This creates intermediate 1. Secondly, intermediate 1 reacts with scopine to create intermediate 2. Finally, intermediate 2 undergoes N-methylation with a methyl bromine to create tiotropium bromide. How is tiotropium structure related to its activity? Tiotropium binds to the residues in M3 receptors. It forms hydrogen bonds with asparagine and serine, ionic bonds with aspartic acid, and pi-pi stacking interactions. The structural pharmacophore for all anti-muscarinic drugs is an acetylcholine analog. This pharmacophore generally is classified as an amino alcohol ester. We will summarize and explain the changes made to atropine to produce tiotropium. Firstly, in tiotropium, there are 2 thiophene rings. These prevent a conformational change required to signal the G-coupled protein by binding outside the active site. Large thiophene rings enhance binding to the receptor. Antagonists are bigger than agonists. This suggests that the thiophene rings bind outside the binding site of acetylcholine. The area surrounding the binding site of acetylcholine is hydrophobic in nature, therefore the rings must be hydrophobic. Secondly, this structure has 2 hydrophobic groups compared to 1 in atropine, which increases potency. The hydroxyl group increases binding strength by participating in a hydrogen bond interaction at the receptor, as is seen in atropine. Thirdly, the distance between the ring substituted carbon and the amine nitrogen can vary from 2 to 4 carbons. And finally, the positive nitrogen present in tiotropium can bind to the anionic aspartic acid residue in the muscarinic receptor. When the nitrogen is made quaternary, the molecule loses its oral availability, but leads to compounds that can be administered effectively by inhalation. Its quaternary ammonium structure decreases its ability to cross lipid membranes, such as the blood-brain barrier. This is why tiotropium causes less side effects.
What are the side effects of tiotropium? Anticholinergics block acetylcholine from binding to its receptor on certain nerve cells. They inhibit parasympathetic nerve impulses. These nerve impulses are responsible for involuntary muscle movements in the gastrointestinal tract, the lungs, urinary tract, and other part of the body. The nerve impulses help to control functions such as salivation, digestion, urination, and mucus secretion. Blocking acetylcholine signals can decrease these functions. Tiotropium has on-target and off-target side effects. On-target side effects mean that the drug will bind to the M3 receptors outside of the lungs. Off-target side effects are when the drugs bind to different receptors. The on-target side effects include dry mouth, which is the most common adverse effect. The binding of tiotropium to M3 receptors in the GIT leads to reduced salivary and gastric secretion, and this can also cause a cough. The off-target side effects include arrhythmias. Tiotropium binds to M2 receptors in the heart, which would increase the heart rate due to an increase in AV node conductions. Other side effects can include blurred vision, urinary difficulties, headache precipitation, exacerbation of narrow-angled glaucoma, dizziness, and nausea.
In conclusion, tiotropium is an anti-muscarinic antagonist that binds to M3 receptors in the lungs for the treatment and maintenance of COPD. It was originally developed from atropine and is produced by a three-step synthesis of scopine. Tiotropium binds in the receptor by pi-pi stacking, hydrogen bonding, and ionic bonding. We hope this video has been informative. Thank you very much for listening.